Well, good afternoon, everybody. I'm so thrilled to, first of all, that this set of lectures on heart failure exists. And I think this is a fantastic program to help all of us improve heart failure care across all sites where we see patients. Heart failure is common, and improving how we um, standardize our care of the management of heart failure is a very noble and very fruitful goal. So I'm thrilled to be a part of this. So thanks a lot for that. I am a cardiologist at St. Luke's Health System in Boise, and I am the director of the Heart Failure Clinic. Next slide. I have no disclosures. My references are included here, so you've got access to those. Next slide. I did promise I would have this done in 19 minutes, so I'm going to move along at a fairly good clip, but try to pause when the important stuff comes up. So thank you. So we'll review who is appropriate for outpatient decongestion and heart failure. We'll outline how we know it's heart failure. So how do we know with some degree of certainty at the bedside that heart failure is what we're dealing with? How do we do it? And how do we deal with the patient not responding to what we do? How do we monitor that response, and how do we follow up and then make that event fruitful in the management of the patient in the future? And then how do we apply this to a practical case example? I know that Bill's case today doesn't necessarily fit into this bill, but we can also talk about why not. So moving on. Next slide. So, as has been said at every single one of these talks, heart failure is a leading cause of hospitalization for patients in the Medicare population and leading cause for readmission. So, this is a giant public health issue. Many exacerbations are driven primarily by congestion without reasons that this patient has to be hospitalized. Stable patients can be managed safely at home with some guardrails. Effective outpatient diuresis can, and I think this is really part of the meat of this, it can evolve to a patient-centered strategy to intervene even before the patient sees you in the office next time. And so trying to make an outpatient managed congestion event into a strategy to help manage the next one with a lot of patient involvement and engagement, I think is fruitful here. And outpatient management, of course, keeps costs down. It definitely improves patient quality of life. And I think it can create the partnership with the patient that is useful in what is a lifelong disease once you have it. Next. So outpatient decongestion is the management of pulmonary venous and systemic venous congestion in a patient with suspected or probably known heart failure that's achieved at home. We use oral loop diuretics, either starting or more often escalating doses compared to baseline or compared to prior use. Short courses of adjunctive thiazides, a few other additional diuretic techniques and agents. And then if you're fortunate enough, a clinic or day hospital IV loop diuretic access if you have it or can make it happen. Outpatient decongestion should always be embedded within guideline-directed medical therapy. Not that you won't have to maybe interrupt guideline-directed therapy occasionally, but this should always be part of a much bigger picture in managing these patients. Next slide. So the right patients are the hemodynamically well patients who aren't presenting in cardiogenic shock. They're warm. They don't have early evidence for cardiogenic shock. They aren't the hypotensive patient who isn't usually hypotensive and without other reason for same. These should be patients who don't suddenly need a much higher flow rate of home oxygen if they're on it, or need oxygen therapy if they aren't on it. And these shouldn't be patients with new dysrhythmias. They should be able to cooperate with an outpatient decongestion regimen, and they need to have access to coming back and coming in if escalated care is necessary. Next slide. High-risk presentations, I think, are the ones that we all know. Hypotension, signs of poor perfusion, chest symptoms, or anything that's been their anginal equivalent in the past that suggests that this is not just congestion, but also ACS, and maybe ACS is driving this, so acute coronary syndrome driving this. Any new lightheadedness, events that are that make you suspicious for dysrhythmias, unexplained change in heart rate that is well beyond the range that you're used to seeing in this patient, obviously severe hypoxia, significant AKI with electrolyte derangements that would make it unsafe and unproductive to try to diurese at home, and then social factors that just don't create a safe situation for managing an acute situation at home. Next slide. So what is that antecedent trajectory? How did this happen? Is it sudden? Was it a slow progression? If this is a patient that you know well, has this been a gradual gain in weight? Is this sudden? And were there any obvious triggers that are patient-based besides just dysrhythmias or evidence for ACS? Is there something that happened in the patient's life? Ran out of meds is a common one here, and one that really encourages me that I'll be able to manage this as an outpatient. So vital signs, weight, and history definitely counts. If you know what type of heart failure that they have, is this HFpEF or HFrEF, how they've responded to diuretics in the past, and what their baseline renal function has been, it can make it much easier to sort what your strategy is moving forward. Next slide. So volume status, neck veins, I'm still a fan of a 45-degree exam and then sitting upright if it's so high at 45 degrees that you can't see it. Any change in lung exam, particularly effusions, which can make it tougher to sometimes sort RELs, but easy to tell that there's an effusion, which is a likely part of the story. Does the patient have a new S3? Is there a new murmur or an enhanced murmur compared to what you're used to? I think we're all very familiar with mitral or tricuspid regurgitation increasing when the patient is volume up because of annular dilatation. And I think we need to be mindful that that change in that whole systolic murmur can be evidence that decongestion is a reasonable strategy here. Is there a change in rhythm? Where are they edematous? Where are they holding on to fluid? Again, back to a shock exam. Is there evidence of normal capillary refill? Are they chilly? Are they thinking clearly? And then finally, if you're fortunate to have point of care ultrasound, that can be helpful. You can measure the IVC and its collapsibility, and you can image the lungs and look for evidence of bilateral pulmonary edema. Next slide. So the bare minimum for laboratory tests in a patient that you need to do significant decongestive work are a BMP and probably a magnesium. NT-pro or BNP itself can be helpful to support your diagnosis or to track a trend, but if you know the patient well, and sometimes even if you don't, this may not necessarily be required in order to chart a course forward. If you aren't sure what you're dealing with, definitely can be helpful. Additional diagnostics as indicated, as listed here. A chest x-ray is not always necessary if the evidence is clear. It could certainly help to look for a lobar pneumonia or something else that you need to be treating differently. And then an echo if you don't know the heart failure phenotype. Next slide. So it's important to remember that this is true and still true. The effects of diuretics on morbidity and mortality are uncertain, and so they are used to treat congestion. They are not used to manage the trajectory of heart failure in and of itself. They have, of course, a class 1 recommendation for use during congestion, and you can ramp up what you're doing with diuretics as needed to manage congestion, but this isn't the strategy for trying to change the trajectory of heart failure. A necessary intervention, but not a long-term strategy. Next slide. So why? Randomized controlled trials have not shown a reduction in mortality with the use of diuretics. Non-randomized evidence does demonstrate that 30-day all-cause mortality and hospitalization for heart failure with diuretic use is reduced compared to no diuretic use after hospital discharge for a heart failure exacerbation. Next slide. So we use loop diuretics as the primary straightforward and generically available management strategy here. Furosemide, bumetanide, torsemide. The dose equivalents are listed here. Bioavailability and half-life matter, and we'll get to that. And even for a stable patient with ongoing diuretic needs, choosing wisely based on those biochemical characteristics of the diuretic can really help in your partnership with the patient to manage congestion. So a short-term intensification for a patient you know to have heart failure is usually a double of the current daily dose. The dose trial looking at hospitalized patients used 2.5 times the oral dose in IV form in the hospital for heart failure exacerbation. We generally simply double what the patient has available at home, and oftentimes you can achieve success. If you have a lot of volume to remove, particularly in right-sided heart failure, you can double the daily dose so that you get adequate response as a threshold drug and give it twice a day. And generally, we advise about 6 hours apart based on the half-life of Bumex and Lasix. Next slide. So these are our drug choices. Thiazides can be added when you're failing with a loop diuretic. Chlorthalidone is our drug of choice because of its reasonably long half-life, as you can see here. And from Bumex to furosemide to torsemide, I tend to use furosemide as a first-line drug, bumetanide when I am concerned about bioavailability, and torsemide when twice-a-day dosing is not reasonable for a patient for whatever reason. Next slide. Diuretic resistance will become an issue for many patients that we are decongesting, particularly those with renal dysfunction at baseline, and particularly those who are on loop diuretic and requiring loop diuretic as a part of their routine management in addition to GDMT. So when we are trying to decongest in the outpatient setting, we'd like to be able to track with the patient how well are we doing, and weight is a reasonable surrogate for that. In hospital at home at St. Luke's, we do try to the best extent we can, track volume of urine output, ins and outs. That can be really challenging when you aren't in the confines of some sort of organized program. So weight as a reasonable surrogate for those who are able to weigh themselves helpful. So 1 to 2 pounds per day would be a anticipated effect, and perhaps more for the patient who's third spaced into the body tremendously. Watch for reasons that the patient is resistant. High sodium intake, NSAID use, poor medication adherence, which can happen even when you're organized around trying to decongest. Hypotension that limits the dose of this or of other medications the patient's on for heart failure to begin with, or significant or progressive CKD, which you'll be checking for. Increase the loop dose to react to this within a safe range. Switch to a higher bioavailability loop. So if you're on furosemide, I would switch to Bumex or probably torsemide for once-a-day dosing. And then you could consider a single IV dose in an urgent care setting if you have that available, or an ER if an ER visit is absolutely necessary. You may be able to manage a situation in the ER and then come home and continue decongesting there. Next slide. So a thiazide type drug, commonly chlorthalidone or HCTZ or metolazone, can be added to increase the positions of the nephron that you're creating a block and creating increased urine output. I would use this fairly cautiously, particularly metolazone, because of hypokalemia and hyponatremia. If I use metolazone, I use it usually once every 2 or 3 days rather than daily, to augment outpatient diuresis when needed. MRA agents here are primarily mortality benefit in HFrEF. They are a 2B in HFpEF. They reduce the risk of hypokalemia, and this will yield mild additional natriuresis because you are achieving something close to total nephron blockade if you're using thiazide plus an MRA. Acetazolamide can be helpful, tolvaptan can be helpful, and I think not useful probably in the outpatient urgent decongestion setting. Next slide. So to remind us where we're acting, at the proximal convoluted tubule, at the loop, and at the distal convoluted tubule, we are primarily in the urgent outpatient decongestion setting, going to focus on those three drugs and of course thiazides as well. Next slide. SGLT2 inhibitor is likely already on board, can be added, won't be a big assistance in acute decongestion, but if you have a patient who has a congestive event and is not yet on SGLT2 for any form of heart failure and is not contraindicated, it needs to be added. Perhaps not as a part of that decongestion event, but soon. Next slide. Before intensifying diuretics, because you see that you're not getting the response that you need, it is useful to check BMP and a MAG to begin with, recheck within a week if you have significantly intensified the home regimen, and then adjust other drugs based on lab trends and on symptomatology. Urine sodium I find helpful in the inpatient setting. It may not be that practical in the outpatient setting. Next slide. And continue where you are able to, and much of the time you'll be able to continue the GDMT that you are already on. Consider a temporary dose reduction or holding RAS blockers if the patient becomes hypotensive as you remove volume, or if there's a marked rise in creatinine, or you're having issues with hyperkalemia. Beta blockers can be continued unless there's a clear low output state, and likely that's a patient who's not going to be appropriate for outpatient congestion regardless. The MRA can be continued with careful follow-up of electrolytes as well. And then the SGLT2 can be continued if they're already on it with follow-up renal function, as you're going to be doing it anyway. Next slide. Non-pharmacologic support, and this is where our wonderful dietitian and social work and care transition team in our clinic come in, trying to encourage the patient to do the things that they can do to be a part of this work, and that can perpetuate into the long-term management of events like this. So daily weights, fluid and sodium restriction within limits, not hyper restricting, but restricting physical activity as we can, addressing comorbid conditions. If we haven't been doing that, do it, and then continue to monitor for evidence that we need to escalate care. Next slide. And when to escalate, if some of the features that were absent in the initial assessment become the case. Do we now suspect ACS? Do we now have higher oxygen requirements to maintain SATs? Are we now hypotensive? Have we had dysrhythmias or symptoms to suggest dysrhythmias? Are we now not mentally clear? And has there been any evolving renal dysfunction that suggests that we can't do this at home? Next slide. And then document where you're at. Document what worked so you'll know for next time, and then scheduling quick follow-up, be that by phone, telehealth, or in person, so that you know that you're making progress. And so again, you're forming a partnership with this patient to keep out of trouble next time. Next slide. And I didn't quite make the 19 minutes, but we're close. So I would welcome any questions.
Thank you so much, Stefanie. That was amazing. That was a great overview of strategies to decongest our patients as outpatients. I will start things off if that's okay. And while I'm asking my question, if others could start putting theirs in the chat, or think about raising your hand. Um, so, Stephanie, can you talk about your heart failure clinic at St. Luke's and what resources are available to you in your health system to care for patients at home, to keep them out of the hospital? Do you have an advanced kind of hospital at home program? Do you use self-monitoring in all of your patients? What's the role of nurses? Kind of what is your ecosystem for that, and how has that changed over the years? Is it better now than it used to be? Just speak to some of those.
Sure. Well, I guess first of all, we have a heart failure clinic that has been active, taking patients out of general cardiology clinic and focusing on heart failure management for a little over a decade. And that I think is an achievement in and of itself. But beyond that, we have been able to grow the clinic to include incredibly powerful ancillaries in the management of this disease process. Two of those are actually on this call. So we have a social worker who is embedded in our clinic who works for our care transitions program. We have a dietitian embedded in our clinic. We have three nurses who are able to do home visits at no cost to the patient, not as part of home health, but are able to dock in with the patient based on that patient's particular needs. Some people can't organize their medicine. Some people have low medical literacy and don't understand what they need to do in order to be successful. Some patients, our nursing staff for care transitions can even go to other appointments with them, can help get them transportation. We really do have a lot of shepherding that we can provide to patients. Many of our patients, and I'm sure that I'm not unique in this in our clinic, are troubled by social drivers of health that lead to congestive events, certainly, but also lead to poor management of this as a long-term disease process. And so we are armed with that. We also do have a hospital at home program. And so patients must start in the ER. They can't come from our clinic because of the regulatory environment that we're in, but from the emergency room, if a patient is from an insurance standpoint eligible for a hospital at home, they can be enrolled in hospital at home. They are managed at home with on-site visits. They're managed with IV diuretics and their other medications at home. And then as they get through that congestive event, then are discharged back to management in the clinic. They, of course, are not on telemetry. And so patients who come by heart failure congestive event on the basis of rhythm are not appropriate for hospital at home. But many patients that maybe fit the worse end of the continuum of those that I described that we can decongest as an outpatient would be appropriate for a hospital at home. One thing that has done is it most definitely keeps an ER visit shorter if we know they're hospital at home eligible, and it keeps patient beds open because we've got, like every single city in the country, too few beds for all the patients that need to be hospitalized. So we're well resourced, and that means a lot to us. And it often means that our care transitions team is catching a congestive event before it happens. We've been very fortunate. I realized that a lot of clinics, and even my clinic years ago when we weren't resourced like this, don't have these tools. But the payoff when a hospital system is able to invest in these tools is extraordinary.
Yeah, that's great to hear. Um, what other questions are there from the audience? I'll ask another one if there aren't any. Um, So what about the patient that ends up getting admitted for whatever reason to the hospital, and then you're diuresing them in the hospital? What has been your practice in terms of when are they able to then go home? Do you like to diurese everyone to kind of their dry weight in the hospital and then discharge them? Or are you trying to get them out of the hospital as soon as possible? And What kind of helps you make that decision?
Well, we've been fairly lucky that we have not been in, we've not been pushed to early discharge by utilization review as often as I expect that we might.
Mm.
So we don't, and our hospitalists don't, I think, feel a lot of pressure for early discharge. To that point, I think that we are notorious, just as a group of care providers for heart failure, at decongesting part way and sending home still wet. It may not be evident, but there's still volume up. And so if I had my fantasy world, everyone would go home euvolemic. It's hard to get everybody there because I think oftentimes we just don't necessarily know what euvolemia is for a patient. So sometimes it's the uncertainty. What I really appreciate and what I think the data suggests too is that a day of oral diuretics in the hospital to prove that we're maintaining and holding our own is very useful. Many of the patients that come to us in our clinic, for example, we don't know. They've never seen us. This is their first ever heart failure event, but they've got HFrEF, for example. They get diuresed in the hospital. They get sent home on a guess of what loop will manage to maintain euvolemia. By the time they see us at day 7 or 8, they've already gained weight. And that would have potentially gone better had they gone home on a higher dose of loop. We do try to get everyone out on 4 pillars, and we have a lot of project work in place to try to encourage that for the discharging team. For many patients who that is not achieved for, it could have been achieved. So as much as we can, we try to be on 4 pillars for HFrEF and diuresed to dry, and with a buffer day of what can we maintain on the loop that we're going home on. I'm curious what you see in your hospital system.
Yeah, I mean, every hospital is different. There are pressures to get people out in some hospitals. Yeah, I was just curious if you have those resources to care for people at home, it might be reasonable to discharge someone if they have a clear kind of structure for continuing diuresis at home. But yeah, all your points are very well taken. Bill, what is your question? Go ahead.
So, my question is sort of as a family physician, they're on a loop diuretic, they've been on it for years. I'm sort of managing them. And I'm wondering when could I consider tapering them? Because maybe it's just from inertia. They're just on their 20 milligrams of furosemide and their 10 milliequivalents of potassium. And I'm sort of thinking about the patient who isn't having any symptoms of congestion, no shortness of breath on exertion, and their renal function, their potassium is sort of in the normal zone.
Well, I'll take this, but then I'd be curious for others on the panel as well. I would probably start by going back to the why. What is the phenotype of their heart failure? What other drugs are they on? Are they on other GDMT that also serves to diurese or maintain volume status? And if not, would you consider a transition to an indicated drug? Inertia, when you've got a long problem list and something isn't currently the problem of choice, the problem showing up today is, I think, normal part of everything that we deal with in managing these patients. But we do know that outcomes improve when we maintain volume with guideline-directed drugs. And so what we do in our clinic, because I will tell you that in a heart failure clinic, we face the same thing. We try to come off the loop when we can. So if we've been euvolemic for a while, we're on other drugs, we've done a lot of teaching around avoiding the big swings in sodium intake that can drive mini congestion events, mini, not many, but mini congestion events. And we've maximized the doses of the meds that we think are indicated for whatever their phenotype of heart failure. We try to come off a loop. And in part, I think that for some of our patients, particularly HFrEFers, it saves us some blood pressure to bump the doses of GDMT. And sometimes it'll give us room to get on GDMT that we've not been able to so far. But maintaining euvolemia, obviously, for a patient functionality, comfort, etc., is awfully important. So If there is some other drug that is more better indicated, better data driven, try that. And I think that with partnership, you can see how it goes with your patient. Their blood pressure is controlled. Again, look at the why. Why were they on it to begin with, and then sort it out. Very reasonable to try to come off. And then we usually have people have it as a PRN, and we'll tell them to both notify us and take it for a weekend of 3 pounds in a day or 5 pounds in a week. You'll tell if that's going to go poorly quickly, right? As soon as you stop it, 5 days later, you get the phone call and you're like, okay, this is not going to go well. But it's worth trying, and particularly if you're struggling to gather meds on board for this heart failure patient, I would try it. But I'm
That's great.
curious for others to answer that too.
Yeah, I think maybe we have a minute if anyone else, Sean
Yeah.
or
Yeah, I can comment to that. I mean, a lot of times I kind of view people who have been dealing with heart failure a long time, kind of like your diabetic, who they learn themselves and they learn how their body's going to respond. So if they're a reliable patient, a lot of times I'll say, okay, you've been euvolemic for, I don't know, 6, 12 months. Why don't we try going as needed, and you do your daily weight still. Your sodium intake is fairly stable along with the fluid intake. And usually that works pretty well. And then close follow-up, and they let me know how much of the diuretic, if any, that they're using. With HFrEF, if their EF recovers, say they're alcoholic induced and now they're sober and their EF is normal. Obviously, it's pretty easy to get off of diuretics at that time. But
yeah, I agree. It's very patient oriented and related to the patient's ability to kind of self-manage their symptoms.